Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to have Guy Deeming joining us. Guy, thank you for joining me.
Hi, Farouk. Thank you so much for having me. It's a real honour and privilege to be here.
So, I'm going to give a bit of background on Guy. So, Guy is an orthodontist who qualified in the UK from Newcastle in 2000. He did specialty training from the UK at Guy's and Kingston Hospitals and qualified in 2007. He's part of the Align or the Invisalign Advisory Board. He's also the Director of Professional Development for the British Orthodontic Society. Guy is a well established businessman in orthodontics and he has over 9 practices. And I was really keen on the conversations I had with Guy in the past to bring him on and really share his insights into aligners, as that is his main clinical focus. So thank you, Guy, again for joining me.
Thanks for having me, Ryla.
Okay, so Guy, the most recent thing that's happened in the world of orthodontics has been this consensus statement, this massive body of work that came out last month and was published in the Progress of Orthodontics, and it was just looking at aligners. Now, they had a range of statements there, and I just wanted to go through the key items that they described and really get your opinion on it as somebody who, in their own clinical practice, has advanced themselves in the use of clear aligner therapy. So, the first thing I want to mention from the consensus statement was that aligners are a suitable alternative for mild to moderate crowding. And the clear line treatment is comparable to that, if not shorter, in timelines to conventional fixed appliances. In that respect, are we not looking at aligners being the go-to appliance when it comes to these mild to moderate cases?
I think the first thing I would say is that the paper was really interesting, and the statements and the conclusions I think are really interesting, and it's very hard to argue with many of them at a high level. But the devil is in the detail, and the truth is in the detail, and there's a lot of failure, I suppose, in the conversation around this to acknowledge the other variables that contribute to the strength of those statements. But to address that particular point, then yes, I think there is absolutely no reason that we can't look upon clear aligners as a appliance that is as good as the fixed appliance alternative for those mild to moderate class one crowding cases. And that's certainly how most people tend to develop their aligner practices and clinical experience. And it's something I think most of us would have no truck with. Um, so, yeah, I think that's a perfectly reasonable starting point.
I think then as we go through the rest of the statements, we then start to see the discrepancy of clear aligners relative to fixed appliances. So if we have a look at the statement made regarding expansion, it mentions that expansion with clear aligners is achieved primarily through crown tipping and not through bodily movement. Then we start to look at which teeth aligners struggle with. It mentions premolars and canines, especially for inclinations and rotations. I suppose one of the biggest statements that they've made there is in relation to extraction therapy, noticing the limitations with clear aligners relative to what else is available. So, though we've got this more ideal potential efficiency with clear aligners in simple cases, for the more involved cases, the more malocclusions that need to be corrected, the consensus statement really points towards both in terms of transverse changes, in terms of posterior movements happening, as well as extraction cases, the limitations of clear aligner therapy. Now, you touched upon it being comparable in terms of fixed appliance and aligners in that initial statement. Where do you stand in relation to these more complex movements and where clear aligners? Do you agree with the statements?
I It's hard to disagree, as a headline, that if you just take a standard set of aligners and attempt to do those more complicated movements without understanding aligner biomechanics and developing your own protocols and treatment plans to compensate for some of those biomechanical shortcomings of moving teeth with plastic. And we must remember here that the success of clear aligners is a construct of the relationship between the plastic and the enamel, the surface area of the tooth. And failure to manage that will lead to a reduction in predictability, whatever that movement might be. And the challenge that we have with some of those movements that you describe is that they simply put more stress upon that relationship between the plastic and the tooth surface. So developing protocols as individual clinicians and specialists, which is what we are, to go some way to compensate for some of those inherent shortcomings of not having something fixed to the tooth, is takes us probably somewhere nearer to the truth in my clinical practice. So to address the high level point, yes, those movements are less predictable if you just have a plug and play approach to aligners. And indeed, there is a diverse range of clinician experience and training underpinning that. However, with experience, with training, and with more refined, individualized protocols, not only for you as a clinician, but also for that patient that takes into account root shape, size, form, and crown shape, size, and form, you can go some significant way to compensate for those. But let's also not forget that by far and away, in my experience, the biggest variable with any clear aligner treatment is the patient themselves. That having a patient that is truly engaged and collaborative with their treatments allows the clear aligner plan to develop and express itself in a far more predictable way than a patient that is somewhat lackluster in their approach. You don't have that with a fixed appliance. Even if they're as miserable as sin, they still generally turn up and you've got the thing stuck to their teeth. So that it's almost a truth that dare not speak its name. And as time goes on, the cases that I have that go brilliantly with clear aligners, and let's be honest, it's not all of them, but it's an increasing majority, it all relates to the relationship that that patient has with you as a clinician and the plastic that they're putting in their mouths. And with that holy trinity, great things can be achieved with aligners. Without that, nothing can be achieved.
I think that's a very interesting point, and maybe these statements or the consensus statement should have all been caveated with the patient being compliant or potentially not being compliant in some of their outcomes. And I suppose there's always this disparity, isn't it, Guy? You've got research on one side saying appliances aren't that effective. You've got clinicians with experience on the other side saying, well, actually, I think they are if they're tuned in the right way. And we've got this kind of dichotomy that's there. And I suppose the question is, well, one, can you give perhaps your insight as to why there is such a discrepancy? Why is it when they're doing research on clear aligners, they don't seem to get as good results as you're being suggestive of? And secondly, is this something which is, as we go forwards in time, are these two worlds going to come together, or never shall they meet? And actually, research always stays on one side, potentially just the ivory tower, if we use that terminology. And actually, clinical practice is always going to be somewhere else. And we're seeing actually a greater divergence now taking place, where actually research isn't necessarily mapping itself now to what we see in clinical practice and potentially won't.
So that's a huge question, and I'm going to try and unpack it in a logical way. And I think the first point to make, and it can't be emphasized enough, is the biggest discrepancy of all is the pace of development of the clear aligners themselves, but more importantly, the software and the algorithms, and the pace of producing good quality research from randomized controlled trials. And on a good day, if something is launched into the market in a clear aligner, it's going to be at least 3 to 5 years before a meaningful piece of research appears in the journals, and then the world has changed beyond measure yet again in that intervening period. And that presents a huge problem with reconciling this mismatch between aligner enthusiasts' clinical experience, which may be very positive, and some of that evidence produced from research, which is perfectly valid, but relates to a different point in time. The other, and I think that probably is the main thing, but the other thing, by very definition, research of quality has to be based on minimizing the variables or ironing out the variables through various different statistical or research techniques, which is, again, right and proper. But what it then fails to do is to look at that variable that I've already alluded to, which is not only patient compliance and collaboration, which is a word I prefer, but also clinician experience and enthusiasm. And whilst I am not a fan, and we would all accept that, I am a clinician on a, ivory tower showing my best cases is not great research. There's something in that I'm enthusiastic and have invested time, effort, love, care, and experience and years into developing the techniques that make me able to deliver better outcomes for this appliance. So the question, I suppose, is where is the truth between what a aligner is actually capable of And should we be looking at the truth of the very best, most enthusiastic practitioner and patient producing the very best results, or should we be looking at your standard jobbing orthodontist and your average, medium to, enthusiastic patients? Because actually, they're going to produce hugely different results, whether we like it or not. And most of the research is legacy based and based on that second combination of a diverse range of clinicians and patients. But then maybe that's more representative of what the average orthodontist is going to achieve when they start clear aligner treatment. But I don't think it's fair to say that is the limit of what is possible with clear aligner treatment. The two things are very different.
Yeah, and it's great you didn't mention my name there as being the most average orthodontist, but
I consider myself a very average orthodontist. I just happen to quite like clear aligners.
I like that. So it's almost as though, well, the progress in the technological development and the pace that we see can somewhat perhaps map itself to how clinicians are when they start using clear aligners, and there's perhaps a greater range of development there, both in the technology but also the individuals start to use it. I want to go down to some of your truths, Guy. Is that, where do you draw the line as to where you'll say, okay, this case of this complexity, this is a no go for clear aligners? What's your no goes, or should every case be amenable to clear aligner therapy?
I think I look at every case with an open mind and open eyes, and I don't look at the teeth. And this is I'm trying not to sound too worthy about this, but and I think we all do this, but I think it's so critical with clear aligner treatments. I look at the patient themselves as an individual, and I look at the relationship they have with their problem, their presenting complaint, and the way they present to me in the clinic in terms of their level of drive and motivation to seek a solution to their problem, and of course the specifics of their problem. And I think it's widely accepted that we as orthodontists risk trying to achieve Andrew's six keys in all cases, regardless of the patient's issues, expectations, timeframes, or indeed their approach to treatment. So what are my no-goes? Well, my no-goes are the patient that isn't engaged and isn't enthusiastic and doesn't understand their role in delivering a great outcome. So I'm quite choosy, not necessarily the malocclusion, but the patient, actually. And if somebody has unrealistic expectations of time frame, because treatment is, in my hands, a destination, not a duration, or unrealistic expectations of perfection. Well, we don't do perfection. We do the very best that I'm able to deliver with the appliances in the context of your underlying your relationships, etc. And then we have a grown-up conversation about it. And if somebody is saying, well, I can't possibly wear fixed appliances because this, and this, I work away or I'm on stage or whatever it might be, and then we compromise around the treatment objectives with aligners, and then they can make a choice. Do they go for no treatment, compromised treatment, comprehensive treatment, whatever that might be? So that said, when I am looking at particular dental or occlusal or malocclusal features, the ones that give me the real fear and really are a red line to this day are the non-crowded, deep bite, retroclined adult, low angle. And they tend to be the ones that have, tooth wear anteriorly from potentially having 4 fours extracted when they were kids and some optimistic URA treatment. And they're almost impossible, I think, to treat predictably, arguably with a fixed appliance either. But very, very challenging to express both the deep bite and the torque, particularly in the absence of crowding, which allows you a huge amount of relative overbite correction with a clear aligner system. So those are the real red lines for me. The other ones are the patients who present with incredibly small teeth. And this is the other variable that I don't think is spoken about enough. That when you've got somebody with walloping great big teeth, you've got a fantastic opportunity to create that interface between the plastic and the tooth surface. And it's something that I never see written about, discussed, or referenced in the research. But alongside patient collaboration, I think it's one of the biggest variables in delivering great outcomes. Patients with big teeth who wear their aligners get amazing predictable results in almost all cases. Patients with small teeth and or poor collaboration simply do not. And it all comes down to surface area and the third variable of time. So tooth enamel, plastic, time. And that bit like the fire triad of oxygen, fuel, and heat. It's very similar with Invisalign, clear aligners.
Yeah, I just hope your practice doesn't catch on fire. So,
Yeah, quite.
in terms of what we see on social media, so we see some really extreme stuff happening in all contexts of orthodontics, but clear aligners, especially so, I feel we see some malocclusions, 10 millimeter AOBs, for example, resolved with anterior open bites. Do you think that is just the progress of where excellent clinicians are and the rest of us still catching up? Or do you think actually that is a limitation and actually this is just an extreme, a one off, a case sample of one, and actually we should have a line where this is not the modality for treatment, besides the, like you mentioned, the deep bites?
It's all down to clinical judgment, isn't it? And I think this is probably going to be a recurring theme as we go through our conversation this afternoon, that we remain the conductor of the orchestra and the ultimate arbiter of the clinical decisions and outcomes. And when you see 10 millimeter AOBs, the conversation that led up to the decision to treat in that manner is something that we're not always party to. And what was that conversation? Was that conversation around, look, this is an incredibly unpredictable treatment. However, taking into account your preference, the challenges, whatever it might be, it is not unreasonable to have a go, but I cannot promise full correction. And then off you go, and lo and behold, in certain cases, you get the most fantastic results. And that's brilliant. And that's a perfectly reasonable and ethical way of approaching that case. If you are marketing that case on the basis that you can do that for every single patient, then that would be unreasonable, because that's probably not true and is not a fair representation of what you are able to achieve in the majority of your cases. But it's certainly possible to achieve extraordinary results in that type of case with clear aligners. And it's certainly possible to fall somewhat short, whether that's down to those we've discussed, clinical experience, skill, protocols, or patients. But then I would also counter that, actually, how many of us would, with absolute confidence, take on a fixed appliance case like that and promise the world? We would approach it with any sense with the same caveats and conversation that I've just described for approaching a clear aligner case. Even, dare I say it, with surgery. None of these things come with cast iron guarantees. The challenge is that when patients see it and expect perfection, it creates something in their minds that can become problematic further down the line, which then reverts back to my previous point around the very first and most important decision is around the patient's suitability for a collaborative adherence or compliance reliant treatment.
Guy, I want to go into now having a conversation about aligner companies and where we stand in terms of planning those cases. Are we simply just becoming technicians to this increasingly evolving complex software where the orthodontist seems to be standing by the wayside, observing the digital processes taking place? And to just put some flesh on the bones of this particular point, Flavia Artesi spoke this year at the American Association of Orthodontics meeting in Philadelphia, and she described aligner companies in the context of interproximal reduction. And I'll just quote, not verbatim, but what I recall her saying. And it was that excessive IPR is planned by aligner companies due to a pervasive intent to reduce the number of aligners to save costs. In the evolution of watching things happening on a screen and digital algorithms taking place, we may not be privy to observing these, what she describes as pervasive intents. So, are we just the recipients now of what the aligner companies give us in terms of software planning?
I, I, I hear this quite a lot, and I must say I find the quote ever so slightly odd, because anybody that's done any clear aligner treatments will know that they can choose very easily between whether that case is planned with IPR or not. And if you've not invested time in your clinical preferences and protocols, whatever platform you're using, to say, I don't want any IPR or I do, you simply get what you ask for. Now, that's a legacy comment, because originally clear aligners were much more simplistic, and the very idea of treating complicated case or extraction cases was, out the window. But that's not the case now, in my view, and indeed in the view of the aligner companies. So the reason they used to talk more about IPR was because they couldn't manage extractions. But that is very much a legacy issue, which now no longer applies. And turning on or off IPR within your clinical preferences is a single click. It makes very little sense, that comment, in the context of contemporary aligner treatments across all of the manufacturers. The second issue is that, again, it's something that I hear quite a lot from, smile more, speak less approach, sitting in the corner listening, and it's people conflating the treatment plan and the algorithms. So they're two very separate things, and people tend to talk to them in the same breath, and they're not the same thing. So what I mean here is that we as clinicians must have and always will retain ultimate decision-making power over the treatment plan. And that is to say, do we extract? Do we not extract? Do we do IPR? Do we not do IPR? Do we do single arch, dual arch? What sort of AP correction do we want? All of those things that make up a treatment plan. They are ours. They remain ours. There is no aligner company that can ultimately make those decisions for us, and that is ring-fenced and protected. Now, what the aligner companies can do and do and are doing is developing a set of protocols that underpin their software to allow us to render our vision for that patient and that patient's treatment plan, firstly in software and then in plastic, to help us deliver that treatment plan in the most predictable way possible. And those algorithms are what the aligner companies are investing huge amounts of time, money, and hours in, not the treatment plans in and of themselves. The two things are different. Now, it is no different if you look back to the old days of a fixed appliance. So pre-adjusted edgewise appliance, it was no different. But yet suddenly the pre-adjusted edgewise appliance comes along, and then suddenly what have you got? You've got a system which has algorithms that allows us to more predictably deliver our treatment plan for that patient. It is no different. It's just on a different level of sophistication, and the language or the semantics of the language has become blurred between the treatment plan and the algorithms. So, to address the point, no. If you understand clear aligner treatments, and if you take control of clear aligner treatments, as we should as independent autonomous clinicians, then the aligner companies are absolutely not forcing us to be technicians. Quite the opposite. By developing sophisticated protocols and algorithms to allow us to deliver our treatment plan, the technical work is actually taken out of our hands, and we get to become, sounds slightly highfalutin, but the artists of orthodontists, to engage with the patient, to engage with the conversation, to engage with the treatment plan in a much more meaningful way. And that's incredibly exciting. But let's be very clear, and let's move that conversation beyond we are just the puppets for aligner companies, because that's not true. If you want to just accept the first ClinCheck they ever send you or the first plan they ever send you and click go, then you have nobody but yourself to blame. But that's your choice, not the aligner company's choice. They're just doing what they think is best because you put an order in to make some aligners. If you haven't set up your preferences, if you don't understand or don't invest the time in developing your ClinChecks and revising those and refining those in the context of your skills, your expectations, and the patient's, then I think it is only right and proper that you should be judged on that basis, because you are behaving like a technician, not a clinician.
I really like that analogy, Guy, about drawing the idea of the prescription in pre-adjusted appliances and using that to explain, well, that's how aligners and algorithms are heading forward. So that's a really interesting insight into that process. Another comment which gets made around aligner companies is the sheer profitability of aligners as a sector. So to give you some numbers, the compound annual growth rate is 13%. We've got, if I just give you some numbers from Align 2019, 2.3 billion, 2025, 4 billion, almost twice the size. Straumann this year made a statement that they're expecting 20% growth. These are exceptional percentages in the world of business. It leaves some orthodontists feeling that they're being exploited by commercial companies from a profitability perspective. And that seems to be a thought which is also mapped to, well, let's take back control of all aspects of aligner therapy. And rather than having the algorithms derive it from big data, let's do in-house aligners. That takes us to both the profitability side as well as the planning side. What's your thoughts on orthodontists who have that as their outlook on commercial companies and aligners?
It's a David and Goliath thing, isn't it, really? People feel a little bit threatened by large companies or large corporations, whatever sector they work in. But whether we like it or not, these organizations across the world are a force for change and development. And that's true of orthodontics. And not only has their investment and their growth generated a whole new sector of orthodontics, and actually let's also remember that to some degree, this is a consequence of orthodontists failing to recognize the needs of patients. Now, we've spoken a lot, about cases and teeth and so on and so forth, but at the end of the day, when you look at research, a lot of that is about whole life gain. It's about a higher level of health outcome. And very much the same is true as orthodontics, that what aligners have allowed patients to do is to have some orthodontic benefit without the burden of the conventional treatments. And orthodontists' failure to recognize that and develop that themselves has led to the vacuum being filled by the large corporate aligner manufacturers. It's not their fault, they're businesses. It's arguably more our fault for failing to do that ourselves. And of course, the problem is then they become too big and they become too big to fail, or they become monopolies in the market. And that's no longer true of clear aligners because we've seen the emergence of quite a lot of competition in the aligner market. But the curious developments or the curious enthusiasm for, let's call them DIY aligners or in-house aligners, I truly don't understand. Partly from a business point of view, I don't want to dedicate time, staff, governance, mess, worktop space, accountability for the manufacturing process. I don't want that. I want to predictably get a set of aligners in my practice in a given amount of time at a given quality level with somebody held accountable, and importantly, have that underpinned by a software platform that is going to work really, really well for me. Now, it so happens that as an Invisalign user, I also get to benefit from one of the most high profile, well recognized public facing brands in dentistry, which is great from a business perspective. But if you understand the rules of the game, then that actually is a very healthy relationship. And I've spent a lot of time with the team at Align over the years, and I remain impressed by the work they're doing and trying to do. I remain intimidated by the challenges that they face of trying to do what they do within the four walls of a multi-billion dollar multinational company. It is not easy to do what they're trying to do because they've got the attitude of a tech startup with the burden of now being a multi-billion dollar multi-international site business, and that's a real challenge. But understand that challenge and understand that we want the same things, and understand that there is regard for the necessity of the clinician to drive that treatment plan, and actually that relationship becomes much healthier than some would have you believe.
Guy, I want to get on to going back to teeth, can't escape. So there's two case types which get discussed in the realms of aligners and orthodontics with polarized opinions associated with them. So you've already mentioned extractions twice now, but let's go into it from the research side to start with. So Fan Day's study in 2019 looked at extraction cases and they reviewed things to see how the movements actually took place. And what they found showed a lot of anchorage loss taking place of the molars of 2 to 3 millimeters, retroclination, extrusion of the incisors. Essentially, the rowboat effect seemed to take pretty predictably within that piece of research. And it's one of the most quoted ones in terms of looking at aligners and extractions. If we go to the other side, and if we look at expert users, so Diego Pedro, he's been on this podcast previously, he described how the protocols for extractions, the company's protocols, do not work. In your opinion, where do we stand with how to deliver predictable cases with extractions and aligners?
I don't want to bang the same drum again, but patient selection in terms of attitude and tooth size. Big teeth, much more potential. Engaged patient, much more potential. I would say younger patient, much more potential. So if we've got large teeth in a young patient with a great attitude, my threshold for case complexity goes up significantly. So what would I undertake with a degree of trepidation? So certainly low angle cases with large posterior spaces such as E's or 6's, I tend to take a very pessimistic view on how well I'm going to be able to manage those, particularly in terms of the tipping forwards of the 7. I'm not saying it's impossible, but I am saying in my hands, I find that challenging to do. I tend to get a little bit of loss of control of the 7 in a 6's case, for example, in the lower arch in particular. In the upper arch, it's a similar story, but the threshold is a little bit higher because we all know that spaces tend to close a little bit easier in the upper arch. But nevertheless, because the 7s tend to have somewhat smaller crowns, you've got the surface area problem, so you need to work quite hard to compensate for that. But there's no shame in that. It's okay. It's not because aligners are rubbish and we should never use them. It's because that is a challenging situation to deal with. And you might, for example, need to use an auxiliary, be that a sectional fixed appliance even, be that a hook attached to the tooth to give you a better control over the center of rotation. There's lots of different ways of doing that. And that's just part of us being clinicians and developing a treatment plan. And it doesn't mean that clear aligners are appalling and should never be used in those cases. It means that they need to be used with the right set of tools for that particular job. Now, I have treated all of those cases at various different points in time, and some of them have gone better than others. And one of the biggest challenges is time. The fact they do take quite a long time regardless, and you do get a little bit of fatigue kicking in for the aligner wearer once you're getting above that kind of 18-month, 2 years, particularly in the kids. So that's another quite important thing to consider when you're taking on complicated cases. Is it because aligners are biomechanically flawed, or is it because patients in and of themselves are flawed in the sense they get aligner burnout or they get compliance burnout? So as you're getting towards the tail end of treatment, they tend to tail off a little bit, and guess what? So do the teeth. I don't know. I don't have an answer. But I certainly know that cases that we go harder and faster in tend to go better and better, rather than the ones where we plan them for 328 aligners on the basis that we can achieve Andrew's 6 keys and the most glorious orthodontic result. Because guess what? That ain't never going to happen.
Yeah, I want to see that clean check guy. I want to see it.
Yeah.
128, I want to see them. In terms of distalization, this is described as a really positive movement with aligners. And again, if we go back to the research side of things, having 2.6 millimeters or so and 80% plus predictability. However, when we start looking at some of the other aspects of research that look at this, they describe how a significant amount of tipping does take place. So the crown may move 2.6 millimeters, but the roots only moved 1.13, and that's Shen's 2024 study. So are we just tipping the teeth back distally, in which case there's a question there about stability, or are there mechanisms to actually achieve bodily distalization with aligners?
Yes, you can move teeth backwards to some degree in my experience. But it's about diagnosis. So young patients again, no 7s, no 8s, all factors. Good elastic compliance, but also looking at the initial tip of the teeth. So when you've got 7s and or 8s or 6s, whatever they might be, that are somewhat more mesially tipped and or rotated palatomesially, there's huge potential to create a class 2 correction effect by derotating and distally uprighting those teeth. So if you get the diagnosis right, looking at a combination of the scans, the clinical and the OPGs, then suddenly you can do incredible things moving teeth backwards in a way that I feel more confident doing than I would with a fixed appliance, because of the way Invisalign is quite effective at those pushing movements. And I tend to find it's quite anchorage conservative, because you get such a good surface area contact anteriorly because you've got all that lovely plastic over those teeth. Now, in terms of true bodily distalization, well, it's the same problem as closing the gaps. You tend to get some tipping or some engineering tolerance within the plastic itself, which means that there is effectively slop in an aligner just as there is in a bracket. So if I was distalizing with a fixed appliance, I would have the same kind of challenges to a greater or lesser degree because of all of the same types of things. So I do look at cases and think, is this one where it is suitable for distalization? But I don't look at Invisalign or clear aligners as manna from heaven to say that I'm going to be able to distalize every single, full class 2 case into a full class 1 regardless. I don't think that's true and ever was or ever would be. But I do think there are some biomechanical advantages of a clear aligner approach in certain cases, which means that distal movements are relatively straightforward, useful, and predictable. And again, it comes down to treatment plan, it comes down to expectations, and it comes down to actually, can we really ever do massive amounts of bodily movement unless we're doing, using lots and lots of TADs and, got the patience of saints and all of the skill set that comes with being, guess what, an enthusiastic TAD user, because enthusiastic TAD users can do incredible things. But I can't do those things with TADs, but I can do things with clear aligners that other people can't. It's no different.
That's really good, Guy. And I want to now look at the education side of things. So you've mentioned this kind of disparity between average and kind of high-end users and what they're able to achieve. And perhaps it's a little bit, and I may be incorrect here, perhaps it's a wider tent than it would be for fixed appliances. In terms of what education should look like with aligners, for specialists that are qualifying for most of the world is an academic component, it's a 3-year program based on fixed appliances. Should there be a separate training program to become competent at becoming aligner practitioners or using aligners as specialist orthodontists? Do you think a 3-year fixed appliance program based on fixed appliances should give you the first principles enough to be able to use clear aligner therapy without any further training? What do you think?
So, a specialist training program, I don't think we can now look at that as a fixed appliance training, and we certainly shouldn't be. We should be looking at that as a fundamental training in orthodontics and orthodontic biomechanics. Now, traditionally, and to a great extent contemporarily, that is still orientated around using a fixed appliance to deliver outcomes for patients. But a good quality specialist training should be about biomechanical principles, orthodontic diagnosis and etiology, and then some technical skill around delivering that with a fixed appliance. So once you see it like that, it doesn't strike me as being a huge leap towards delivering those same outcomes or treatments, employing those biomechanical principles to a clear aligner system or a lingual appliance system. There is a point here that I think, again, is not spoken of that much, is that lingual appliances 10, 15 years ago were incredibly popular, and they were very much the talk of the town. And people were incredibly enthusiastic about them, and they were almost put on a bit of a pedestal as being, only the very best orthodontists use lingual appliances and deliver great outcomes with them. And I struggle to see the difference between the learning curves to become a great lingual appliance practitioner and a great clear aligner practitioner, because you still have to go through a learning process and a learning curve to do both of those things. But yet, why do we view them so differently? Why are we so disparaging in some corners about clear aligners? And I can't help the feeling it's simply down to the fact that, we as orthodontists always viewed that we should have wires and brackets and pliers. And there was a certain status that came with a lingual appliance system. And people feel the opposite about clear aligners, and it's to their detriment and disadvantage. But if we view development of clear aligner skills in the same way that we view development of lingual appliance skills, then I think we'll have a much more positive relationship with our own personal development, but also the sector as a whole, if we're feeling a little bit more cynical about it. Because lingual appliances, of course, same things. It was send them an impression, they sent you some appliances. Guess what? That was the treatment plan in inverted commas, or the algorithms. And how many of us just accepted the first one that was sent back to us? We thought it was great, but we don't feel the same about clear aligners. I don't know why.
That's really insightful. So that the programs, as long as they are, and I think majority of them are good programs, do offer a biomechanical basis to it. The specialist should be able to adapt that for aligners.
But the other problem with that, of course, is that do the skill sets exist within the academic institutions to be able to give people the technical skills to be able to deliver clear aligned treatments? I don't know. I mean, I have huge regard for my academic and university and teaching institution colleagues, but that's a really important factor, isn't it? Because if you've got somebody that isn't enthusiastic or experienced about it, then it is doomed to failure.
So I suppose in terms of what's available, what happens in teaching institutions, there's quite a range, I suppose. Some institutions in the UK, for example, where we are, will get potentially 2 cases to treat. Some institutions will give no cases at all. Colleagues over in the US, they'll get 10 potentially plus clear aligner cases to treat with. And suppose the question is, there's such a variability to the training that specialists who are coming through in today's generation have when it comes to clear aligners. What should be the standard? What should be the minimum requirement to practice clear aligner therapy as a specialist in terms of what education that you've received? And if that's not really being delivered, Guy, by the teaching institutions, and you're making some inference in that direction, where should trainees who want to become specialists who are using aligners, where should they go for that kind of education then? Is that just the commercial companies now? Are they to sit down and try and work out themselves? Is it mentorship? What should they be doing?
So if a newly qualified specialist or a teaching organization or the combination of the two have not managed to create a world or an understanding where that specialist has a full knowledge of the biomechanics and orthodontic treatment planning diagnosis, then that course has, to my mind, probably not quite met the brief. And with that information, a specialist with zero clear aligner experience should be able to take a step back and think about the appropriateness of treating a given case with clear aligners to a greater or lesser degree. So they should be able to make, an informed professional specialist assessment of a case, understanding biomechanics and with some basic principles of clear aligner treatments, understand whether that is a good or a bad idea. So I don't think there is a black and white line about suitability or what that training should be. It comes down to professional autonomy. When is this suitable within my competence? And it's no different to anything else. When is this within my competence to deliver with a supplier? So that being said, there is a necessity in that context to deliver some core biomechanical training in clear aligners within the courses to allow people to do that. Even if they don't get that much direct exposure to how to actually do the treatments, that's less of an issue if we consider what I've said about the difference between treatment plans and algorithms. But in terms of the day-to-day delivery of clear aligner care, then it would be lovely to see that within university programs more, or even within parallel university programs or additional supplementary, major minor style, trainings within there that you could opt in to do a part-time program on cleft or clear aligners or whatever it might be. I don't know. You decide. But where we're at the moment is that a lot of the training historically has been done by the aligner companies themselves, which is fine because there are often very specific system orientated trainings